The Appropriations Subcommittee on Labor, Health and Human Services, Education, and related agencies will come to order. Certainly, good morning. Glad you're here. We've decided it's okay to start on time, so we're starting on time and anxious to hear from you. I want to thank our witnesses for being here. This is a critical issue in this committee. As Senator Murray and I began to work together on this committee 4 years ago, we really made the first substantial percentage increase that year on this effort to look at opioids. I think we increased the funding by about 300%. And that was not an insignificant amount of money, but compared to what we're spending now, it was pretty easy to make a 300% increase. And then really that discussion driven in so many ways by members of this committee from our states, from New Hampshire, from West Virginia, and other places, has got us to where we are, and we are anxious to hear from you. In 2017, almost 50,000 lives were lost due to this crisis. That equates to about one life every 11 minutes. It's the deadliest. 2017 was the deadliest year on record for this disease, killing more people than lost their life at the peak of the HIV crisis in the 1990s. While those numbers are bad, the overdose deaths obviously are not redeemable. They only reflect a tip of the iceberg. For every person that loses their life to overdose, there are 300 other people who are misusing prescription opioids during that same period of time. Every state across the country feels the impact of this crisis. My state, Missouri, is no exception. Talking recently, our staff was to the mother of a St. Louis native and Navy veteran, Derek, who was just 2 months shy of his 30th birthday when he lost his life, when he lost that battle that had been going on for 12 years. And during that 12 years, Derek had graduated from college, earned an MBA, served in the Navy proudly, but the addiction that had started from a high school football accident finally led to his death. His mother, Kelly, is really a powerful voice in the fight against this epidemic. I want to thank her and so many other people who have taken their tragic experience and moved forward to try to help others prevent that tragedy and deal with what they're really dealing with. We've had a steady increase of synthetic opioid use, and the DEA in St. Louis recorded more than a 1,600% increase in fentanyl seizures from 2016 to 2017. We saw in our state a 40% increase in fentanyl-related overdoses during that same period of time. It's clear that the crisis is not behind us. This subcommittee has, I said to start, really, I think, been at the forefront of talking about this before even we had the kind of expanded legislative authority. Now we were beginning the process of expanding funding. Over 80% of the investment the government's made has come through this subcommittee, nearly $9 billion in the last 4 years. And I think we're beginning to see some signs of improvement, and that's one of the things we want to talk with you about today. Federal funding in Missouri has provided over 4,000 people with treatment, saved, we believe, 2,000 lives through overdose reversals, and the rate of overdose deaths is beginning finally to drop. There is a lot more to do. First, I think we have to realize that behavioral health issues have to be treated like all other health issues, that mood, anxiety, and other disorders can double the risk of addiction, but also just realize if you don't have a behavioral health issue before you become addicted, you certainly have a behavioral health issue after you become addicted. Secondly, we need to reduce the number of people who become addicted in the first place. The committee's provided resources to expand surveillance in every state, to educate physicians through prescribing guidelines, and to start an education campaign. There's evidence that these efforts are beginning to work. The amount of opioids prescribed in 2017 declined by nearly 30% from the year before. but we have to continue to talk to this about both the prescribers and to patients. And lastly, we need to look for better ways for pain management, and we're trying to do that through the research dollars that, again, this committee is making available. This is an area that we have moved forward on together in a bipartisan, dedicated way. Senator Murray's certainly been a great partner and a great part of this. And Senator Murray, I'd like to turn to you for your opening statement. Director Stringer, you mentioned, one, the importance of getting the money out the door, and that SAMHSA's gotten that money to the states quickly, and you believe monitoring, but that's not, my real question, I think, is on your observations about how important it would be to continue to work through the states. I assume that means as opposed to working directly with local providers. You all know from the way we've dealt with this, we haven't tried to prescribe a solution here because we don't know the solution, but we're giving the states a great deal of flexibility. So first of all, I'm going to ask you, Mark, about the importance of working through the states. And then, Dr. Cropsey, I'm going to come to you and talk about and ask you about ways we can evaluate how the states are doing. We've given money to the NIH specifically to do that, but I think there are other tools out there in addition to the NIH. So first of all, Director Stringer, the importance of working with the states and the importance of getting that money out the door.
Sure, I very much appreciate the question, Senator. Working with the states, number one, allows the states the flexibility to direct those funds where the need is the greatest, which is exactly what we did with the STR and the SOAR grants, where our worst problem has been in the eastern region, primarily the eastern region of the state and the Boot Heel, some in the southwest. So we were able to target those areas with those funds. Secondly, we were able to coordinate those funds with other federal grant programs, with our existing programs funded with block grant and with state general revenue, so that we did not have redundancy, we did not have inefficiency, but it is a well coordinated system that I'm very proud of. So I think again that the flexibility, the consistency, and the quality is what we see when these funds come through the states.
I would assume from this panel that there's no disagreement with that, at least until we find out what works, and maybe even after we find out what works. But on that topic, again, we've given some specific directions, some specific money to NIH, but Dr. Cropsey, I know a lot of your work has been in trying to figure out what treatment works, how do we evaluate whether inpatient is better than outpatient, is a 30-day intense program better or a longer commitment, and just talk about evaluating what is out there and how we share what appears to be working and share what appears not to be working.
Well, thank you. So we do know that obviously medication-assisted therapy has been life-saving and has been critical in saving lives, as we've heard from other panelists. I think that is well known and well established. I believe also that the behavioral treatments that go along with medication-assisted therapy, cognitive behavioral therapy, also are critical in reducing addiction and are important. You know, I think what is less known is if someone goes to a specific treatment facility, what happens when they leave 30 days, 3 months, 6 months after that facility. And I think that if you were able to incentivize facilities to collect that kind of data or to provide resources to be able to collect that data, we would have a better idea of how we could figure out what happens after an inpatient treatment program or what happens after someone is in an intensive outpatient program. Right now, that data is not captured particularly well at the individual agency, like treatment facility level. And so I do think that that would be important to be able to collect. And whether it be some sort of outside evaluator that partners with those agencies, or whether it's the agencies who are incentivized to collect that data.
Let me get to another topic here. On the question of what would we do without this $3.7 billion. I just want to be sure the record reflected that in 2015, we had the Affordable Care Act. This is not, in my view, a hearing about that. We had states, most states that were going to expand in Medicaid had, but that was not doing the job. 2015, 60% of people estimated that needed mental health help didn't get it. 25% of that 60% didn't know where to go to get it, and some of the others just chose not to get it, but it generally was not available. I continue to think that, treating behavioral health like all other health is an important addition to our system. So, Director Stringer, we're one of the 8 states in the 8-state pilot where we're doing that with the certified community behavioral health centers. You and I were one of them last Friday, and really one of the most rural counties in our state. But we have pretty good access for this pilot period all over the state. Would you talk a little bit about how that being available at the same time we got into the opioid response made a difference in how our state could respond to that?
Sure, Senator. And we heard from a lady at the roundtable who benefited from the comprehensive set of services that were available there, so that she was able to get treatment for her substance use disorder, as well as for her mental health needs, as well as for her living needs, and consequently was successfully in recovery. So I think the comprehensive approach that you and Senator Stabenow have designed has really, again, it's transformed healthcare, and when I say healthcare now, in the spirit of what you're talking about, I'm including mental health care and substance use disorders. And so when someone comes into one of our certified community behavioral health clinics now, they are seen not as a diagnosis but as a person with complex needs that we address in a holistic way and as thoroughly as possible, and we continue those services so that person gets in recovery, stays in recovery, and thrives.
Beginning to see yet any emergency room numbers responding to that, or part of the pilot is to frankly see what impact this has on people's overall health needs if you're also treating their behavioral health needs like you'd treat any other health problem. You see 2 years into this or a year and a half into this, are you beginning to see anything you can share with us?
Yeah, and we have absolutely seen improvements in a number of domains, and I can get that data to you, Senator.
Okay.
But we were followed out as Dr. Gowdy and I left the roundtable discussion. We were followed out by a juvenile judge who came up to our vehicle and was saying how much he appreciated some of the services made available through the CCBHC that were, again, comprehensive, that allowed us to go into schools, that allowed us to go really where people are, find them and give them the assistance that they needed. So we are seeing improvements in healthcare. We're seeing improvements in criminal justice system. We're seeing improvements in employment and just in overall quality of life.
Right. In one of the, Oklahoma is one of the other states, and I was in a meeting the other day where they said at one of their major hospitals that has developed through the law enforcement and other places to go, a 70% reduction in the emergency room in that system, because almost all of the behavioral health people that were coming there now have a better path to somewhere that they can't just go that night, but they can also begin to develop a permanent place to be.
Yeah.
Senator Murray,